Melda Debarkment syndrome, or persistent postural perceptual dizziness. I will talk about the off-label use of antidepressants for the treatment of chronic dizziness. Now, so when you think of dizziness, you might picture this, kind of, person, head spinning, cold sweating, trembling. So this is not a depiction of a patient with dizziness. This is a depiction of how neurologists feel when they get dizziness consults, right? And so, I'd like to convince you, though, that it can also be very gratifying and somewhat fun to kind of figure out why patients have these symptoms. And some cases are really easy, like this, particular Wheel of Fortune puzzle, but others are really difficult because this is all you have, right? So see how long it takes you to figure out what the answer to this puzzle is. Okay, so I'll just kind of start entering them, and you can raise your hand as soon as you know what this is. Right. And so believe it or not, the person who guessed this was a contestant who guessed it with just the very, very first picture of just that one E. And so that can be you making the dizziness diagnosis after you've seen enough patients with that one kind of critical historical or exam finding. So all that vague history will melt away, and you'll be able to make a huge difference in that person's life. Now, the other less vain reason for you to learn how to have a working diagnosis and strategy for dizziness syndrome evaluations is that they're just extremely common, right? So at least 30% of the population will experience moderate to severe symptoms of what they might call dizziness sometime in their lives, right? And the presentation of dizziness represents one of the most common chief complaints of people seeking medical care and at extremely high cost. So think of all the patients that you know who have had something like benign paroxysmal positional vertigo diagnosed after they've had a brain MRI, right? So it kind of behooves us to have some reasonable approach to evaluating these patients. So what you want to do is to have a system for getting at the key components of the history and then understand why you see certain findings on the vestibular exam. So in 1 hour, we can't talk about all the causes of chronic dizziness, and giving you like lists of dozens of causes of dizziness is also not helpful in general. And so what I want to do is to kind of focus on how to get sort of high yield historical and exam findings, and particularly with respect to getting comfortable with peripheral versus central vestibular abnormalities. And as I mentioned, the review article on chronic dizziness from a couple months ago has several different syndromes, including these 5, as well as motion sickness. And so again, if we have some time to get at them at the end, we can. You can also have copies of the slides if you request them. Now, for the medical students in the audience, it may be tempting to try to memorize these kinds of charts, right, where they kind of divide people into, well, this is dizziness and this is vertigo, or this is some other description. But these types of charts are almost pretty much always wrong. And the reason is that they're oversimplistic, right? Because true vertigo, along with other sensations of imbalance or spatial disorientation, they often go together, right? And symptoms can have episodic exacerbations on top of a chronic baseline. And sometimes these charts are just like frankly wrong, right? For example, where they put Melda Debarkment syndrome is incorrect, because Melda Debarkment syndrome is experienced as a true illusion of movement. In this case, it's not spinning, but it's more of an oscillating feeling of going back and forth, which is the technical definition of vertigo, right? And so, and it is not really triggered, in the sense that something happens and then immediately after you get the feeling, it's actually a continuous sensation. And tumors like vestibular schwannomas and meningiomas, don't typically cause episodic spontaneous vertigo. So I just want you to be sort of aware of when you see these charts, they are kind of seductive in how they like to present this entire world. But what's more important is that you just kind of get to understand like the nature of some of the really common disorders. So one thing that people ask is, well, how important is it to understand exactly what the patient is feeling, right? Does it really matter what they experience? Like, is it dizziness or vertigo or something else? And I would say it is somewhat important, right? But it's only one component. It's very helpful when the patient can be very clear in their description, because if they can clearly indicate that they're experiencing rotational vertigo, it is fairly localizing to somewhere along the vestibular kind of neural axis. It doesn't tell you exactly where, but again, it's just one component. In the real world, of course, people don't come telling you that they experience vertigo or anything even close to it. They will say things like, my head is not right, a wave comes over me, I can't move, I'm not myself, I feel weird, I can't describe how I feel, I just feel bad. And so the goal in general is to at least kind of nail down some wording so that you are on the same plane as the patient. And that's where the terminology can be helpful. So if you want to narrow them down a bit and impose some definitions so that you at least agree English to English or English to a closed translation in another language, this is important, especially if you're seeing them on multiple visits and you need to track the evolution of their symptoms. You need a starting point. And it also really helps if doctors have some agreement between what these words mean. So the International Society of Vestibular Specialists that make up the Barony Society recognized this problem about 15 years ago, that even among super specialists, there was no agreement about what the word dizziness meant. And so they developed some consensus criteria for these definitions. And it seems like simple definitions, but they had to be written in a way that translated across multiple languages. And so according to the Barony Society criteria, the definition of dizziness is a sensation of disturbed or impaired spatial orientation without a false sense of motion. Whereas vertigo is a sensation of self-motion or a distorted sense of self-motion. We generally kind of divide it into internal if the patient says that I'm moving, or external if the world is moving, and they can either be spinning or non-spinning. Now, unsteadiness is a feeling of instability. It can happen when you're seated, standing, or walking, but it should get better once there is some type of external support. If you put your hand on the wall, or if you're just holding onto a stable surface, unsteadiness should get better. Presyncope is a feeling of impending fate. It's covered more in a discussion about orthostatic dizziness. It tends to be on the vascular side. But one word that you want to be really careful about is the word lightheaded. Sometimes people say that they are lightheaded, but people really mean different things when they use that word. And sort of historically, even going back in the medical literature into the 1970s, that word was used to describe any non-specific dizziness. And in fact, that word, when people use that word, tended to cluster around associated mood and anxiety symptoms. And so, because sometimes what people literally mean is that their head feels light rather than that they feel faint. And so you want to, get a sense of whether they have a sense of impending, fainting or passing out. Now, every disorder that causes, oops, I'm just going to slide up here. Yeah, so every disorder that causes dizziness can ultimately be diagnosable by history, right? If you have enough of the historical elements. But some historical elements have more yield than others, okay? So once you kind of get down, okay, this is what the patient means, we're sort of on the same page with what they're saying, there are 4 really important historical factors to nail down. And I just call them the 4 T's, right? Trigger, timing, tempo, and turf. So when obtaining the history, really one of the most important aspects, probably the most important aspect, is to identify the trigger, whether it started spontaneously, what the relationship is with head motion, and whether it is exclusively triggered by head motion or whether it is only exacerbated by head motion. So when there is a latent vestibular asymmetry anywhere along the vestibular pathway, accelerating the head will amplify that asymmetry and cause stronger symptoms, right? So this is a relatively non-specific, feature, right? So symptoms that are worse with head motion can be helpful in implicating to some degree that there's a vestibular asymmetry, but they don't really tell you whether the problem is a primary problem in the vestibular system. So, but it can be helpful if, someone, say, who has like Parkinson's disease, they're fine when they're sitting down and they're actually fine when they're moving their head. This type of historical factor can actually be very helpful, because people with Parkinson's disease typically, they don't seem to be at higher risk of developing vestibular abnormalities than anywhere else. But if the symptoms are only triggered by head motion, there are no symptoms in between, that is usually benign paroxysmal positional vertigo that we'll talk about more extensively later in the examination section. Now, general kind of worrisome features in terms of triggers are whether there are non-vestibular inputs that trigger vestibular symptoms, and particularly sound or pressure, such as loud noises, coughing, sneezing, straining, Valsalva, etc., because that usually indicates that the protective bony casing of the inner ear has been compromised. And so these are the times when you worry about things like superior canal dehiscence or perilymphatic fistulas or the skull fractures. Now, second, knowing the timing and the duration of the symptoms can often narrow the differential down fairly significantly. I'm going to emphasize that with a couple of the next slides, as well as the tempo, right? So, is it a single event? Is it episodic? Does it come? Is it maximal as soon as it starts, and how long does it last, right? And so then you can get a flavor of, is this an electrical, mechanical, inflammatory, or vascular problem, just the way that you would diagnose anything else along the neural axis. It's also very helpful to know if the patient has any normal periods during the time course of their symptoms, right? Because some disorders, for example, like Meniere's, disease, like, you have an attack, you generally go back to baseline, and then down the line, you might have another, another attack, whereas something like a TIA, you might have a bunch of, stuttering little episodes before you have a really severe, full-blown syndrome. And of course, you want to know what the neighboring area entails, what I call turf, right? So are there other inner ear symptoms like hearing loss, tinnitus, or ear fullness? Are there other brainstem symptoms like diplopia, facial numbness, or dysarthria? Or are there general medical symptoms? The really big one being any type of cardiac symptom. So here's kind of a mock-up of the timing and tempo of onset and severity of 4 common causes of vertigo in the first 24 hours. So spells of benign paroxysmal positional vertigo, or BPPV, last about 10 to 20 seconds. They're triggered only by head movements, only occur a few times a day, with most of the day being pretty asymptomatic. People usually have a spell in the morning, a spell at night, and maybe a spell during the day when they tilt their head back. They really should be walking normally in between. Vertigo that kind of crescendos over the course of minutes to hours, lasts for hours, and generally has inner ear associated symptoms like ear pressure, tinnitus, and hearing loss, is the typical profile for Meniere's attacks. Meniere's attacks, by the way, are extremely severe. They are prostrating. Vertigo due to vestibular neuritis generally builds like an inflammatory process, right? So it builds over hours. It's very, very severe. These people are usually on the floor, or they're vomiting, or bedbound. Strokes that cause vertigo, like other types of strokes, may or may have a little period of warning, like a stuttering onset, but the deficits are generally maximal at onset. Okay, 7 days later, right? People with BPPV may still be having some attacks. They're generally a little better by then. Meniere's patients is probably not having another episode at day 7. Vestibular neuritis, is a lot better by day 7, but they're not completely back to normal, but they are walking. The stroke patient is still having problems though, right? So their symptoms might be somewhat better, but the symptoms are still pretty severe, and they may not even be walking by day 7. And so you want to be really careful, in diagnosing something like vestibular neuritis, where the person is like as impaired on day 7 as they are on day 1. So let's move on to the vestibular exams. We'll briefly cover a couple bedside tests of the vestibular ocular reflex called a head impulse test, as well as dynamic visual acuity. So these are things that you do at the bedside that you do not need a whole vestibular function lab, to help you with. Then we'll discuss peripheral versus central nystagmus, and a couple tests that you can add to your regular ocular motility exam to look for peripheral versus central patterns of nystagmus. And what I want to do is to kind of impress upon you why you see what you see, instead of having you like memorize lists of what different features are, okay? And then we'll just do a very brief wording about tests of skew deviation. So let's move on to the vestibular exam. The first one is called the head impulse test. I hope people have heard about this by now. It's not something that we did a lot when I was going through actually not at all when I went through residency. I finished over 15 years ago. So first let me just talk about the vestibular ocular reflex. So the VOR makes compensatory eye movements for head movements. And this is a very fast reflex, happens under 70 milliseconds, and you never know that it's actually working until it stops working, right? So you move your head and you make a very quick, instantaneous eye movement in the opposite direction so that you can maintain fixation, right? So the normal response to a very brief high acceleration rotation of the head when the patient is instructed to fixate on you or to look straight ahead is for the patient's eyes to be looking at you the entire time, okay? The compensatory eye movement, opposite to the direction of the head movement really should be instantaneous. It's so fast that like you can't detect it. If the VOR is slowed because the peripheral nerve or inner ear is damaged, that afferent arc is going to be inefficient. It's going to be slowed, okay? So this will make the eyes follow the head movement and the patient will have to then make a corrective saccade back to midline. So this test is abnormal in something like vestibular neuritis, but is negative in something like a cerebellar stroke because the cerebellum is not involved in this 3-neuron brainstem arc that drives these horizontal eye movements, okay? So this is an example of an abnormal head impulse test, and it is reassuring that it is actually positive, okay? So first of all, you can see a little bit of a left beating nystagmus. So head impulse to the left, he's fine. Okay, head impulse to the right, you can see that little bit of a catch-up saccade. And he's talking here, and so he's gonna actually do this again. It's gonna. Oh, actually, this is the next part. So this person also has a catch-up saccade to the right. Right there, do you see that? So go to the left now. The left is fine. There you go. Okay, so those are catch-up saccades. Okay. Now, when you do this test, you have to do it very fast, and you have to do it with a bit of randomness because they otherwise can start predicting where you're going to go. So this is someone who has a normal head impulse test. So she locks on, right? So her vertigo was not due to a peripheral lesion. Okay. So get comfortable incorporating that to into your normal neurologic exam because it can take a while for you to figure out what normal amounts of eye movement look like. So dynamic visual acuity, this is a bedside test for bilateral vestibular loss. This will be abnormal in even chronic cases of bilateral loss that go on for many, many years. So in this test, the patient reads a handheld Snellen chart to get, you get their best visual acuity, then you oscillate their head at about 2 Hertz and have them read the chart again. It's normal to lose up to about 2 lines of visual acuity. The more lines of visual acuity you lose with this head oscillation, the more severe the vestibular loss is. And so this again is a test that shows a failure of the vestibular ocular reflex to make compensatory eye movements for head movements. And so the patient ends up just kind of seeing a blurred image. Peripheral versus central nystagmus. So I want you to understand why you see these different patterns. Just a word about nystagmus, because I see lots of medical records in which neurologists just say that there's nystagmus, but there's no description of them. It's really important to describe the nystagmus correctly, right? So nystagmus is a slow phase drift of eye position with a corrective movement, which is usually a fast movement called a saccade. And so while we name this nystagmus for the fast phase, because it's what catches our attention, right? It's actually the slow phase that defines where the problem is. The nystagmus that we see with vestibular dysfunction is what we call jerk nystagmus, in which there is a slow drift followed by a fast jerk, as opposed to say something like pendular nystagmus, in which the eye position is sort of sinusoidal. Now, by convention, if you ever see a nystagmogram, if you order vestibular function testing, as shown here, the right side is on top and the left side is on bottom. And so in this nystagmogram, it represents right beating nystagmus. And so when we name nystagmus, we should note the direction of the fast phase, what plane it's moving in, whether it is sustained, and how it is affected by gaze and also head position. Now, eye movements can be very complex. You can't always figure out what the problem is like right at the bedside. And I can't always do that. So what I just try to do is just make note of what I saw and in what eye position, and then after the patient is gone, then I will try to do my localization because I mean honestly it can be somewhat complex sometimes. And just to know, like, not all nystagmus is bad. We kind of think that nystagmus is generally a bad thing, but good nystagmus is there for a reason, right? Because the goal is to keep your vision on a target. So when you're pursuing a moving object, image eventually slips off your retina since your eyes can't keep rotating in the orbit. So you have to perform the slow phase tracking and then a quick saccade back to refixate. It's also vestibular nystagmus that happens when the person is moving, in which you do get a nystagmus that's just a couple beats usually, with very brief head rotations. And so, it's a very brief vestibular nystagmus with head turning during the light even is normal. But if you actually turn off the light and you just rotate someone in the dark, you can actually get vestibularly driven nystagmus lasting even like 20 or 30 seconds. And so whether the world moves, in this case, in this example, to the left or the head moves to the right, the world relative to what's happening on your retina is kind of doing the same thing, right? So in this example, if the world moves to the left or your head moves to the right, the complementary eye movements are actually going to be in the same direction, right? And so what's sort of cool about this system is that the optokinetic nystagmus is actually activated by the smooth pursuit system, whereas vestibularly driven nystagmus is suppressed by the smooth pursuit system. So if you know this relationship, you can actually start doing some really sophisticated types of vestibular testing. Okay, so bad nystagmus is when the nystagmus disrupts visual fixation. And so what I'll talk about is this concept of the neural integrator. That is one of the reasons why we get kind of bad nystagmus. Second, as we know, if you irritate the vestibular system and you cause the vestibular system to have an acute or subacute imbalance, you could get nystagmus. And the other one I won't talk about too much, but we need a healthy functioning visual system to recalibrate the entire VOR. So people who have who are blind, or who have central visual loss can have all kinds of very unusual patterns of nystagmus. So I just want to touch upon this idea of the neural integrator and why you get central nystagmus. So, when the eyes are moved in a position that is different than where they kind of generally want to be, right? Because there are mechanical forces on the eyeball, right, that want to keep the eyeballs generally in sort of this wall-like position. You need to have this pulse command to get the eye where it needs to go, and then a step command to keep the eye there, right? And so this system, it has to be working, constantly while you are awake for you to focus your vision and not get ocular misalignment, right? So if this system is leaky, then the eyes will kind of drift away from the target, right? Now, it turns out that there are some really important parts anatomically, that make up this system. And these substrates include the interstitial nucleus of Cajal in the midbrain, that is the vertical neurointegrator, and the nucleus prepositus hypoglossi and the medial vestibular nuclei that are in the pons and in the medulla that make up the horizontal neurointegrator. But most importantly, the system that provides the error monitoring for this whole neurointegrated apparatus is the caudal cerebellum, right? Particularly the flocculus and the paraflocculus. And so this is generally why you see the sort of central patterns of nystagmus, typically with cerebellar disorders. And of course, this is a somewhat complex system. I don't remember all of this anatomy myself, but when you have cerebellar problems, you can also generally have other types of eye movement issues, particularly with various aspects of smooth pursuit. By the way, if you haven't read this book, The Neurology of Eye Movements by Drs. Lee and Z, it's an amazing textbook and it has a ton of videos. So I would highly recommend it for your residency library. Okay, so here in this video, you're going to see a patient with a vestibular neuritis of the right ear that's creating spontaneous left-beating nystagmus, and it does not change no matter where his eye moves. You also see that there's a slight torsional component to this nystagmus, and we'll talk about why you see that. In the second video, the patient has central nystagmus that changes direction depending on her gaze. So it's not frozen, he's just talking. So here we go. So you see that left beating nystagmus, a little bit of a torsional component, still left beating, kind of decreases a little bit when he looks to the right, but still left beating. And it's labeled as reassuring. You know, it's reassuring that it's not a stroke pattern. Okay, now. It's not frozen. There you go. So she's looking to the right, it's beating to the right. Looking to the left, and she's beating to the left, okay? So, so that is what we call gaze evoke or direction changing nystagmus, okay? All right. And so let's kind of move on to positional testing. So when you see some of these distinctive, you know, features of eye movements, you know, you want to know, well, what, you know, why do I see what I'm seeing, right? And so one important, you know, factor that, you know, you might have learned in your anatomy classes is that peripherally driven nystagmus happens because each component of the inner ear drives eye movement in its own plane. So if you look at the orientation of the semicircular canals as in this MRI scan, you can see that there's a horizontal canal and there's two vertical canals that are kind of rotated off the sagittal axis, right? There's no canal that is, for example, purely in the vertical plane. So one horizontal canal and two vertical canals, 45 degrees rotated from the sagittal plane. So peripherally induced nystagmus can be horizontal or it can be vertical with a torsional component, but it can never be purely vertical or purely torsional. Now, the relationship between each peripheral vestibular organ and eye movements that it drives occurs because of these very specific connections between these organs and eye muscles. So we'll just highlight the nystagmus of peripheral origin through the example of benign paroxysmal positional vertigo. So in this example, the right posterior semicircular canal is connected to the ipsilateral superior oblique muscle and the contralateral inferior rectus muscle. So in BPPV, the otoliths fall out of this gravity sensing organ called the utricle, and they fall into the posterior semicircular canal because it's the most dependent canal. So the particles are heavy, so they go down. Now, if there are loose particles in the posterior canal, you can get them to start moving in the endolymphatic fluid, and thus triggering the receptor of the semicircular canal by turning the patient's head and making them go through a series of vertical head movements, namely head extension, to get those particles to maximally go, you know, around that, that canal. Now, the superior oblique muscle intorts and depresses the eye, whereas the inferior rectus extorts and depresses the eye. So when the projections of the right posterior semicircular canal are activated, the eyes will make a conjugate clockwise slow downward drift, you know, as seen with these red arrows, and then we'll make a corrective counterclockwise saccade to recover. So the correction is thus a torsional counterclockwise upward movement, okay? And this is what it'll look like. I try to pick cases in which the problems are all on the right side, so you can at least have that pattern in your head. Okay, so this is Dix-Hallpike maneuver. You can see it's rotating counterclockwise, and it has a bit of an upbeat component to it. Okay. All right. So now the one, even though this is not a, we're supposed to be talking about chronic dizziness, I do want to talk about benign paroxysmal positional vertigo, how to diagnose it and how to treat it, because I do see that people have problems with this, you know, still. And so I'm going to show you a video. This is my mentor, Bob Balo, showing you how to do a Dix-Hallpike maneuver. And I'm just going to kind of walk you through the steps. So he has the participant, or in this case, our lab assistant, sitting with his head turned to his right by 45 degrees. Then he does a quick downward movement. Okay, you'll have the vertigo nystagmus right there. You wait until the vertigo nystagmus goes away. Do a nice smooth roll to the other side. Now they're looking at the floor. It's really important that that roll is very smooth. In this position, the patient will have another shorter burst of nystagmus and vertigo. That's good. You wait until that goes away, then you have them sit straight up. You always have them wait for about a minute before you let them get off the table, because the particles have rotated all around the posterior canal. They're back on the utricle, which is a gravity sensing organ. So when the particles hit the macula of the utricle, the patient can feel like they are retropulsing. Hold them for a minute. Now, about 80% of the time, one roll will get rid of all the particles. What I always do is to do a second roll to be sure that all the particles are gone. If some particles are still there, I roll them again, and then I do a third roll. It's rare that I have to do more than about 3 rolls, but I always do as many as it takes to get rid of all the particles until I get 1 negative test, okay? The other important thing about doing this maneuver is that you just do it once until, like, you treat the patient and then they're done. You don't do it again until they're symptomatic again. Otherwise, you're kind of chasing your tail with head extension and making the particles fall out again. The instructions for them when they go home that night is to sleep with the affected ear up, so that if any particles go into the horizontal canal during your roll maneuver, they will naturally fall out again just during sleep. Okay, you don't have to have them sleep in a recliner or use neck braces or anything. The particles are still loose though, so it's important that they try to avoid head extension for the next few days. So once again, nice downward movement. And then he's going to do a nice smooth roll. And you don't have to wait like a certain amount of time in each position. The goal is to have the particles continually moving. And so I just use their symptoms and their nystagmus. So once their vertigo and the nystagmus goes away, then I know I can go to the next step, okay? Okay, so you can carry this, concept forward, right, to understand that, well, when it's not just one canal that's affected, but it's the entire vestibular nerve, right, that's affected. Now you have multiple canals that are affected, right? And you also have the utricle and the sacule, which are the gravity sensing organs. So if either all the canals or say one branch of the vestibular nerve, like for example, in vestibular neuritis, you generally have the superior branch of the vestibular nerve affected. You essentially get kind of a summated effect of irritating multiple components of the vestibular organs. And so usually what you end up creating is some degree of cancellation of the vertical components of nystagmus with a stronger horizontal nystagmus with a torsional component. Okay, I'm just going to give you another example of what this looks like. This is another person who has a right-sided vestibular nystagmus, vestibular neuritis. She's going to have left-beating nystagmus. But of course, the reason why you get this, right, is that the right vestibular system is now kind of out of the picture. And so you get this tonic deviation of the eyes to the right from the healthy left side. And then you get this corrective saccade back to the left. And so again, she has this unidirectional nystagmus, and it should always be beating in the same direction, right? Regardless of what direction she looks. There is something called Alexander's law for peripheral nystagmus. If you look in the direction of the fast phase, it gets faster. This is also showing her abnormal head impulse to the right. So she's got that touch-up saccade, okay? Now, it's great if you can see this, if the patient, comes in like the day of their onset of their symptoms, but sometimes if they're, coming like day 3, day 4, day 5, you might not see that spontaneous nystagmus because now they're using visual fixation to suppress that nystagmus. So there is a kind of a nifty bedside test that you can do called Occlusive Ophthalmoscopy that you use to uncover a spontaneous nystagmus that's being suppressed by visual fixation. So all you're going to do to remove visual fixation is you look in the patient's eye with your ophthalmoscope and then cover the other eye. The only thing you have to remember about this test is that you're looking at the back of the eye, right? You're looking at the optic disc. And so if the optic disc is beating in one direction, say to the right, the front of the eye is beating in the opposite direction, right? So just remember that. because we named the nystagmus in the direction that the front of the eye is beating. But this is a very cool, test that you can do, because patients, they're often not coming on that first day. They often think, oh, this is going to get better, and then by day 3 or 4, they're like, I still feel pretty bad. Now I'm going to come see my neurologist. Finally, you can do tests of visual suppression of VOI by rotating the patient in the light. Remember the slide again that showed that vestibularly driven nystagmus should be suppressed by visual fixation. So the easy way to do this is if you have a swivel chair in the office, you can just kind of swivel the patient back and forth while they fixate on their outstretched finger. Or you can do it the hard way, like I did with this patient. I just spun her around being upright. And so these are her eye movements after I had spun her to the left for about 15 seconds. And so you can see that she has this kind of left beating nystagmus. And she actually has this kind of nystagmus because she has an increase in something called the velocity storage system. And I'll show you one reason why. So she has this vestibularly driven nystagmus and it does not get better with visual fixation. And now this is her now after we've rotated her to the right and stopping. So now she's got this right beating nystagmus. Oh, sorry, this is left. Just rotate. No. Now we're going to show you one with the right. So she's rotated to the right. Now she's got this right beating nystagmus, right? So this should never happen, right? Because you're allowing this person to fixate. So vision should be suppressing that nystagmus. So this person had a posterior fossa epidermoid cyst resection, and she had presented with dizziness with head movement. And you would not have picked this up, unless you kind of knew this history, a little bit. But in fact, she didn't even, complain so much about the dizziness. She actually complained about headache. So it does, help to add some of these a little more sophisticated components to your exam sometimes. So quick review: centrally driven nystagmus, direction changing because of the neurointegrator problem, generally sustained, does not suppress with visual fixation, usually associated with other ocular motility problems. Peripheral nystagmus is usually unidirectional, caused by loss of function, as usually in this case. If you look in the direction of the fast phase, the nystagmus gets stronger. If you look opposite the direction of the fast phase, the nystagmus generally gets weaker. And then when the nystagmus is specifically triggered by BPPV, you have a burst and then the nystagmus generally fatigues. But since everything else is working fine, your other ocular motility issues should be, non-existent. So like your smooth pursuit, system and your saccade system, for example, should be normal. Okay? And then finally, only a little bit on tests of skew. Patients with brainstem strokes can present with vertical diplopia from ocular misalignment driven by abnormalities and supranuclear control. And so these patients may present with a head tilt with the eyes rolling in the direction of the head tilt, which is not usual, because normally when you tilt your head to one side, your eyes will counter roll in the opposite direction. So the same side rolling is actually not normal. But what the patient's doing is sort of tilting their head because their sense of verticality is off, right? And so you can unmask this kind of latent vertical deviation by covering one eye and looking for the other eye to refixate. Now you can also get a skew deviation from a fourth nerve palsy, right? But fourth nerve palsies will be affected by the direction of gaze that makes that superior oblique muscle work, whereas a central skew deviation will not be affected by gaze. So you can actually get small amounts of skew deviation even from vestibular neuritis and peripheral vestibular disorders, because essentially what you're doing is affecting the input from the gravity sensing organs, but really large skew deviations are central. And so here is a video of someone with no skew deviation on cover testing, followed by someone who does have a skew deviation. It's still going, don't worry. Oh, there you go. Okay. Okay, so you see how that right eye kind of comes down and comes in. Okay. And so I wanted to highlight just a few aspects of this vestibular exam, the head impulse testing, the nystagmus, and the test of skew, because these test components together make up something called a HINTS exam. And you might have also heard of this, hopefully, during your training. And HINTS stands for the head impulse. Okay, so if that is positive, okay, if you have nystagmus that has a peripheral pattern, and if your tests of skew are negative, right, and the patient meets all three criteria, there is a extremely high negative predictive value that this is not a stroke. Okay, so this is why you want to get sort of comfortable with these tests. And then the corollary is infarct, right? So if your impulse test is negative, right? If the nystagmus alternates, in direction, and if you have refixation on cover and cover testing, then your infarct suspicion is high. Now, finally, because I want to leave just a little bit of time for questions, I want to direct you to this resource, which is the Journal of Vestibular Research. If you go to this website, it's called jvrweb.org, and you look under where it says International Classification of Vestibular Disorders. So this is where you can find some really nice criteria papers on different disorders, and most of the ones that I talk about in that continuum article. So not only are they helpful, I think, from the standpoint of giving you diagnostic criteria to make these diagnoses, they're also like reasonably good review articles to give you a background in a lot of these disorders. And so now there are criteria paper on now the Bregman syndrome that I work on, bilateral vestibulopathy, and presbyvestibulopathy, BPPV, vestibular migraines, Meniere's disease, orthostatic hypotension, superior canal dehiscence, childhood vestibular migraine, and vestibular paroxysmia. There's also a paper in the works on concussions, and the one diagnosis I do want to just kind of touch upon is this diagnosis called persistent postural perceptual dizziness, because this is not a diagnosis that we really made until like a few years ago. And so you might make this diagnosis more now. And so these are patients who used to be called chronic subjective dizziness, visual vertigo, space and motion discomfort. And what people realize over time is that, all those folks who are using all those they were all kind of talking about the same group of patients who seem to have this kind of chronic unsteadiness, worse when they're upright, generally worse when they are exposed to visual complexity or visual motion. They kind of came to this disorder through kind of multiple different mechanisms. So it could have been vestibular neuritis that they didn't compensate well for. They might have continuing vestibular migraines. They could have dysautonomia, etc. And they're pretty, impaired by it. And so you can make a diagnosis of this PPPD on top of whatever is their initial trigger. In fact, you have to have a trigger for the PPPD in order to make a PPPD diagnosis. So you're often kind of making both diagnoses, at the same time. And the important thing about the PPPD, because you will see these patients, is that you want to address sort of that element of it, right? And so regardless of what the initial trigger was, it seems that vestibular rehabilitation is helpful. Cognitive behavioral therapy can be helpful. These patients could often end up developing a lot of fear of falling and a lot of sort of anxious like fearful responses to different types of stimuli. And so you want them to have more of a cognitive strategy to kind of work through those situations. A lot of these patients do have, headaches, and so you deal with any concurrent, pain issues. I think about 15%, 10 or 50% of it might even have like dysautonomia type problems. And so, you want to, address, all those types of underlying, symptoms. And again, but regardless of the cause, it seems that certain therapies can be helpful. Vestibular rehab can be helpful. Serotonergic antidepressants can be helpful. And then, oftentimes we're doing combination therapies. So before I, go on anymore. I just want to leave a little bit of time for questions. Since we have about 5 minutes left, you know, I could go through 12 more slides, but let me just stop right there to just take any questions.
Hello. Hi, my name is Susan Law. I am I'm a stroke neurologist, and thank you very much for giving us the nuances of vertigo and dizziness. I was wondering, in your wonderful slide that talked about the acronym of vestibular and infarct, the signs and symptoms, has anyone thought about using that as a pathway to like an ED observation pathway that you know of for evaluation to avoid admissions to hospitals?
Oh, well, so let me just say, I'll tell you, you know, the history of how I even got into this neurotology world was not even because I was specifically interested in the vestibular system, but because as a resident, we were absolutely admitting everyone for vertigo, for stroke rule out. And so there's got to be a better way to do this, like just to put them on telemetry and give them a $20,000 bill, right? And so, boy, yeah, if we could get everyone in the ED to even do like positional testing accurately, that would go a long way. And if you just even learn how to do the head impulse testing, that would go a long way too. What I'd really like to see at some point, you know, is there is a video head impulse testing apparatus that you can't bill for it, unfortunately. So only certain centers have it, but they're basically these like video goggles, and you do the head impulse, you know, with the video goggles on. So they actually track the eye movements, and you can model the eye movements. So you're kind of not depending on your own judgment, right, as to whether you saw that catch-up saccade. It would be nice to have something really quantitative like that be integrated more into just regular ED evaluations for vertigo. Yeah, no, but but I hear you. Yeah, we don't want. We want to be. We also, you know, not to just save time and money, but we also really worry the patients a lot, right? When they come in with BPPV and we're doing a stroke rule out. So. Yeah, but I would love to see more of a systematic, you know, pathway. So the person who's really who's done just a lot of work in this area is David Newman-Toker, who's at Hopkins. So you know, if you're interested in this area, I would recommend reading some of his papers.
Thank you.
Anyone else? You can. Oh, yes. So remember that, yes, this, so HINTS has become kind of a big thing in our area. So if you have not heard of HINTS, please add that. And then INFRAC, yes, is the mirror reflection of HINTS. Grown-ups, I asked about their childhood, fine sensory. Oh, okay. So interesting about PPPD. Yeah. So I think there's a lot of these disorders that we don't really understand fully. I mean, we know that people who present with migraine headaches in adolescence often have motion sickness when they're children, and then they go on to develop visual aura in their 20s and 30s, and they start developing vertigo in their 30s and 40s. Yeah, so there may be some underlying genetic predisposition, whether it's sensory integration or modeling of external sensory inputs that are not done as efficiently, you know, by some human beings than others, right? So what is the utility of testing using an OKN strip at the bedside versus spinning the patient to evaluate? Well, so an OKN strip, right, is just activating the smooth pursuit pathway. The patient's head is still, so you're just testing the smooth pursuit path. You're activating the smooth pursuit pathway. Whereas when you're spinning the patient, you're actually giving them vestibular stimulation. And what you're doing is you are activating the smooth pursuit pathway to suppress the vestibularly driven nystagmus. And so you are actually testing the smooth pursuit pathways in both cases, but it's like a different kind of function, right? So yeah, so OKN is like you're directly stimulating visual input, and then the spinning is using smooth pursuit to suppress the visual system.
Can you
The
hear
slides
me?
be available, yes. And this is recorded.
Can
Oh,
you-
when should you be using Megazine? I would say very, very rarely. And thank you for asking that. So, so Megazine is very helpful for treating nausea. I would use it very sparingly. You use it really mostly in cases of like vestibular neuritis, where you have a very kind of time limited duration, or even like Meniere's disease, where you have a very time limited duration of that vestibular, you know, either activation or vestibular suppression. And sometimes like in Meniere's disease, you might actually have like an activated phase as well as a destructive phase. What you have to remember is that Megazine is a vestibular suppressant, right? And so if you have something like vestibular neuritis, where you have this demyelinated nerve, and your early recovery is really dependent on that other ear, the healthy ear, now picking up more of the work of detecting head movement in both directions, the last thing you want to do is to suppress the activity of the other ear, right? And so it just kills me when I see patients with 25 milligrams of Megazine around the clock, right? What you do is you use enough so that they're able to eat and drink. And then you know, figure out what their underlying cause is. Yeah, and also you should not use Megazine ever if they're not nauseated.
Can you hear
Thank
me?
you, yeah, Dr. Shaheen, thank you.
Can you hear me?
Any other topics? Let me just give one. I'll just give you one plug for maldebarkment syndrome, because it is what I work on. And I'll just kind of share a perspective on this. So there are people who have this feeling of motion when they get off a boat or a car or train. They have a persistent feeling that they're still moving. And so, and those people seem to be kind of entrained to that kind of prior periodic motion. They often will, I mean, they really suffer tremendously because they feel the motion all the time, right? And so they're kind of never really at peace. Although what's really interesting is that they actually feel better when they're back in motion. So if they drive a car, they feel better. If they walk at a certain pace, it's actually better. So they can actually suppress the motion if they walk at a certain cadence of gait. And so we're actually trying to study that through our gait analysis labs. There's another group of people, though, who present with this feeling of rocking that don't have a motion trigger. They tend to have a lot of headache. And so one of the things that we're kind of looking at right now is whether some of those people might have an underlying kind of vascular etiology, and that what they might be experiencing is a form of pulsatile vertigo. So that's one of our research projects right now, because this group of people, they do not get better with vestibular rehab. You can put them on benzos and they do feel somewhat better, but not that much. And so it's one of the reasons why I study this group of folks, because there's very few, but treatment options for them. And so we try to use neuromodulation, for the first group, who seem to have the entrainment phenomena. And we're trying to figure out what the how do you choose the right treatment parameters for those folks. So that's one set of studies. And then the other one is the spontaneous kind of rocking patients who have a lot of headache. Is there an underlying vascular etiology that we can treat with focused physical therapy? So hopefully in a few years, if you kind of come around to reading this literature again, we'll have a few more things to share.
When
Okay.
there is hello, can you hear me?
Yes, we can hear you.
Okay. Any final?
A patient with a classical migraine who develops in association or during classical migraine dizziness, how much vestibular workup do you recommend?
Oh, I'm sorry. I could not hear The first part of that question, I heard.
The first part is that we take a patient with classical migraine. During the migraine, the patient develops dizziness. How much vestibular workup do you recommend?
Yeah, and I don't know what the issue is with the audio, but so there is a diagnosis called vestibular migraine. And there are actually diagnostic criteria, and you can find the criteria on the JVR website also. They very much model the International Headache Society criteria for just regular migraine headaches, in that the vestibular symptoms are also episodic. They last, 4 to 72 hours. They happen in someone who has a history of migraine, and at least 50% of the vestibular symptoms are associated with some of the migraine symptoms. Now, there's kind of two sides to this issue, right? Because I mean, migraine is really common, right? And so if someone who has a really common problem now develops this other syndrome, right? Is it necessarily related to the migraine? And that's the difficult part, right? That you're trying to figure out, because people with a history of migraine tend to have more of every kind of vestibular syndrome. It seems like they're more likely to have Meniere's disease, they're more likely to have bilateral Meniere's disease, they're more likely to have BPPV. We don't think that they're more likely to have things like, vestibular neuritis, but they might be more likely to have like Melvin-Barkman syndrome, etc. So you're always trying to kind of figure out like, how are these two things related? So if the syndrome, if the new vestibular symptoms follow the migraine kind of temporal profile, mean that they're still episodic, they are usually linked with the migraine symptoms, then I would treat it like the migraine, right? With all your usual migraine therapies, right? Migraine preventative medications, and lifestyle modifications, things like that. But if it's something else, you just say, how much do these new symptoms really just kind of fit another disorder? Then I would just treat them as like two disorders, basically. I would also not assume that everyone who presents with headache and dizziness has vestibular migraine. And so, I think this is just the way that human beings tend to think. There was a time where, we didn't think that migraine had anything to do with episodic vestibular dysfunction, and so no one believed it. And then there was, people just sort of migrated to, yeah, this is a real association. And now in some ways we've kind of swung over a little bit too far the other way, where now we think like every headache and vestibular syndrome going together is vestibular migraine. I think we kind of missed out on diagnosing what the underlying etiology is in some of those cases. This is why I think it's really important to follow diagnostic criteria, so that we're at least kind of speaking the same language when we say that, this is a vestibular migraine patient, or this is a Meniere's patient, and not have a lot of other assumptions. And I'm sorry if I didn't ultimately answer your question, because I'm having a hard time hearing the audio on your side. So, but putting the questions into chat has been really nice. And I'll stay on, I know people have to go to work and everything, so, but I'll stay on to answer questions as people, would find it helpful.
Can you hear me now?
A little bit better, yes.
But the question was, if I see a patient with a typical classical migraine history who comes and complains now of dizziness, how much vestibular workup do you recommend?
How much vestibular
Workup.
how much vestibular workup? Okay, that's what, I'm sorry about that. Well, it really depends on, and that's a great question, right? So one is, if they have hearing loss, at all, they should, they should get an audiogram. And then if it's, and I would always check them for BPPV, right? And if it's not that, And if it doesn't follow a pathway that would indicate that they have vestibular loss, so if they don't have kind of a history of vestibular, like prolonged vertigo, like a vestibular neuritis kind of story, I actually find vestibular function testing to be less helpful than like you would think. And in fact, it's just like the way like a cardiologist might be. The longer that you're in cardiology, you get better at listening to hearts, the fewer echocardiograms you order. And so you also start to learn like what exactly you get out of all this testing. Vestibular function testing is actually very crude. If you can get it, it's not available in every lab. I would get rotational testing rather, in addition to caloric testing. Caloric testing is where you irrigate the ear with warm and cool water, and then you're essentially kind of creating this little convection current of the endolymphatic fluid in the horizontal canal. So it's a really artificial stimulus, right? Because this is not the way your ears work. They don't work one at a time like that, and they don't work with that kind of stimulus. Whereas with rotational testing, the person's in a room and you're actually rotating their head and their body, and that is a natural way that we move, right? Both ears working at the same time. But I would never use vestibular function testing to make my diagnosis, because it doesn't ever point you into the correct story, right? It only kind of helps you to quantify a deficit that you think is already there. But yeah, but I would look for red flags, always, in people with that, with any kind of new vestibular symptom, especially in older patients too. So any type of new onset auditory symptom, anything that is unilateral, any non-vestibular trigger for their symptoms, I would look at that, and if this is an older patient also, I would look at cardiac symptoms more. But I would not screen with vestibular function testing. I think it sends people down the wrong pathway and adds a lot of confusion if they don't already know what they're looking for.
Thank you.
Thank you, and I'm sorry, because I feel like my own hearing and eyesight are kind of going. No one else? Thank you, everyone, for really good questions. So if you have questions about the article, again, I don't want to just rehash everything that was in the article, because you'd be sort of reading, everything over again. But feel free to reach out, to me, and just let me know where you're writing from. I get emails from a lot of places, and so just say that you're from SUNY Downstate, and it's a question regarding this lecture. I'm happy to point you in the right direction, hopefully.
May I ask another question?
Oh, sure. I'm going to lean in a little bit.
Have you ever seen patients with seizures whose prodrome was dizziness?
Oh, seizures? Boy, very, very rarely, actually. And I'll tell you that the two things that I would look at. So I do share patients with epileptologists, who have patients who have seizures and then who have dizziness. And I would say, boy, it is really, really, I can't even think of a case in which the ultimate diagnosis of their dizziness was actually the seizure. There is a disorder called Vestibular Paraxismia that sometimes can be mistaken to be a seizure phenomena. So vestibular paroxysmia, also, if you make this diagnosis, people will think that you are a genius, because it's a relatively unknown type of diagnosis. But if you think of trigeminal neuralgia, right? So you have this vascular compression of the trigeminal nerve that causes shooting pain in the face. Well, imagine that happening in the to the eighth nerve, right? And so these patients will have spontaneous episodes of fairly brief vertigo, lasting seconds to minutes. And if the compression is kind of severe enough, well, it usually kind of comes from kind of posteriorly, it will also hit a bit of the cochlear nerve too. And so before they have the vertigo, they will have a little bit of tinnitus, and it sounds like a typewriter. So it'd be like, and they'll have this, you know, then they'll have the vertigo. So it's really helpful. It's not always there if you get a little bit of that typewriter tinnitus ahead of time. And so sometimes that disorder gets mistaken as being a seizure phenomenon because it's like spontaneous and it has sort of that duration of a seizure. So the way you diagnose this is that you treat it. You treat it with oxcarbazepine, or one of my favorites these days is lacosamide, because it just seems to have a really good side effect profile, and the symptoms should get better. You know, then you want to see like what's sitting there. Is it a vascular compression? Is it a cyst? You know, it can, you know, but you don't want to diagnose this particular entity just by imaging. You know, we get so many people getting MRI IAC protocol scans, right? Because something like 50% of people will look like they have a vascular compression on the 8th nerve. So you have to kind of diagnose this, not, you know, the imaging is kind of confirmatory in some ways, but it's not what makes the diagnosis, right? The diagnosis is the classical history plus the response to the therapy. But seizures as the sole manifestation of the vertigo, I have generally not seen that. I mean, to some degree, it might be an ascertainment bias too, but yeah, I think there's generally other symptoms that go along that kind of point it to, you know, to an actual seizure phenomenon, right? Not just like isolated vertigo.
Do you ever recommend an electroencephalogram?
No, no, I never do EEGs as part of a vestibular evaluation. You know, I mean, if they were to have other types of symptoms, you know, if they had olfactory auras or something like that, you know, but I would be doing the EEG for those symptoms and not for any of the vestibular symptoms. I don't know of too many vestibular neurologists who do EEGs as part of any vestibular evaluation. I know that they're done a lot, you know, because the patients are usually coming to me having had EEGs. But I think you'd have to be fairly specific at what you are looking for. There are, you know, obviously like parts of the brain that if you stimulated them in isolation, because this has been done in brain mapping studies, right? Particularly if you're stimulating over the lateral temporal lobe, but you can cause vertigo, like spinning vertigo. There are other parts of the brain where if generally like in the kind of like the deep frontal lobe, if you stimulate it, you can actually even trigger feelings of oscillation. So theoretically, I think it would be possible, but I think where people usually have their seizure foci, which is more in the medial temporal area, you know, would generally not cause the kind of vestibular symptoms that we normally see, without causing a whole bunch of other more localizing symptoms, you know, that are more suggestive of seizures.
In the EEG, when you look for transient changes such as spikes or whatever, you miss at least half of the abnormality.
Right. So lots of stuff go on in the brain that we can never detect. Yeah, that is true. Yeah.
Well, it depends on how sophisticated you are in your analysis, such as frequency analysis of the EEG, which would allow you, especially if you apply wavelet analysis following the EEG, to catch transient phenomena which are not spikes.
Yeah, but I would kind of go back to what's the general pattern of the person's symptoms, right? And do they kind of follow that type of kind of burst, spontaneous, short duration symptoms, and what are the triggers? And so we're usually able to nail down, some other disorder. So yeah. I've also seen skull-based tumors. So skull-based tumors like sphenoid wing, meningiomas, or even tumors like, like over the cerebellum that can present with it sort of looks like vestibular paroxysmia. And those people actually also respond to anti-seizure medicines. So I think it would be kind of interesting, right? It's difficult to get electrical activity at the base of the skull, but maybe there's something to that, yeah.
Thank you, Dr. Cha. If you have 1 more minute to comment on the last question from the chat about psychogenic dizziness, I guess that's a tough one. When would you diagnose it?
Yeah, so there was this like old way of thinking, like sort of like in the 1970s, right, where they kind of divided different types of dizziness, and psychogenic was like 25%, right? And I gotta tell you something, is that I almost never diagnose psychogenic dizziness, right? It kind of depends on like how many items are in your armamentarium of diagnoses that you can make, okay? And so we don't actually use this term. What we do know is that the pathways that control emotional regulation and learning of fear, right? Like those pathways are really evolutionarily old pathways. And what's really interesting is that they overlap very well with the pathways that are shared with the vestibular system, right? And so, which is also a very ancient system, right? And so it totally makes sense that, like, if you have a spell of vertigo, that you instantly have a, feeling of panic, right? You have a feeling of fear. And when people have panic attacks, I mean, what are they, besides intense anxiety, they have like severe dizziness, right? And disorientation, right? So we know that these symptoms can go together, right? And it is very anxiety provoking to have vestibular symptoms, right? So number one, the episodic ones that you cannot predict. It's like having epilepsy, right? You don't know when your Meniere's attack is going to hit and when you're going to be prostrated. Okay, that's very anxiety provoking. And then there are the chronic symptoms like Melville-Barkman syndrome or PPPD, where you just feel bad all the time. And so you have to just kind of recognize when there is a sort of like an adjustment disorder, right, on top of their underlying kind of primary vestibular syndrome, versus this is essentially someone who is just kind of overly like interocepting, right? There are people who have like very high interoceptive awareness of like how their body feels, right? And their stomach being empty and whatever. So, I mean, that is an actual process, right? And yeah, I mean, I have patients, I would say even most of my patients who have vestibular symptoms are very anxious. I prescribe antidepressants all the time, but I do not diagnose this as their primary syndrome. And
yeah, thank you very much. My question was,
it's usually not like anxiety and like nothing else.
Yeah, thank you very much. My question was not if, obviously dizziness can cause anxiety and all the other symptoms, but whether you can have, let's say, patients who present with chronic dizziness, you can't find anything else. And it looks like, I wouldn't call it conversion, but, maybe in that realm that you don't find an underlying neurological etiology, So from that aspect, I want to ask the question.
Yeah.
As you mentioned,
Yeah.
in the past, the typical was that it's 20% of dizziness is psychogenic. Maybe that's wrong, but
yeah, I don't know. Again, like I would say, like if you're not finding, like if you're kind of hitting a wall and you're like, I can't find what's going on. I mean, there's a whole bunch of disorders out there we haven't even discovered yet, right? That we haven't given names to. I would refer to a neurologist and have them make that diagnosis, right? Because I think they just have a bigger world of really esoteric, I used to work on episodic ataxia, and when I was a fellow, this was my job, is to like coordinate this research consortium of episodic ataxia. It was really interesting how, before episodic ataxia, got diagnosed, these patients were often thought to have conversion disorder, right? Because they would like get excited or be really upset, and then and then they'd fall and they couldn't go to work. And so, so I think, Yeah, and I do see, I would say, functional movement disorders as part of my practice, and that is something to kind of be aware of, because those patients, like if you get them on the right pathway and kind of fix the story, in their minds, like they can be a lot better. I mean, relatively quickly, sometimes too. But yeah, I think just because the evaluation is negative, the default, I would say, for me anyway, is not psychogenic. Yeah, I would just say, I don't know. I would just say, I don't know. I would say, let's work on the things that we can work on that we can't.
I mean, I send them to rehab. I'm sending for vestibular rehabilitation, So it works sometimes.
Yeah, and that can help, So I look at vestibular rehab as a medicine. I don't look at vestibular rehab as, in some ways, my way out, right? And because I work fairly closely with the vestibular rehab people, and so I get referrals from them too. And so oftentimes I will get patients from vestibular rehab, and I'm like, oh, this was a misdiagnosis, right? And so I think you have to do what you can do with the tools that you have. And so, but I think it's also being honest with the patient. It's like, I don't know what you have. Let's try this. Let's try this, and let's work on the components of your syndrome that we do understand. We might not get to the core of it, but let's work around this. So it's actually kind of the story that you tell the patient. But I'm usually not telling the patient, I think your primary problem is actually anxiety. The anxiety can certainly magnify any problem that is already underlying there. So it's like people have pain, for example, and then they become like hyper, like, kind of attuned, to what's going on with this pain and that pain, etc. So we put them into cognitive behavioral therapy so that they can try to, change the pattern of thinking. But I know sometimes what happens with the vestibular rehab people is, the patients are sent to them without a diagnosis. And so, we can't really depend on the vestibular rehab people to make the diagnosis for us. They don't have the training to do that. Unless it's something like, BPPV, that they can diagnose that. But, the higher level sophisticated stuff, I mean, even the really good ones, I don't feel like they're really good at making a higher level vestibular diagnosis. But it's a tough situation.
Yeah, I don't send them for diagnosis. I send them just for alleviation of symptoms, the same way you send a functional patient to physical therapy, because they're going to get better with therapy. And sometimes we have success. That's
yeah. And so like for something like PPPD, like, vestibular rehab is actually very helpful, even like regardless of what their core problem was, right? So you're kind of just like, you're fixing that layer, right? You're fixing the adaptive layer. And in some sense, what you're doing is kind of like cognitive rehab with them, because you're kind of teaching them that, like, you can be in control, right? And you're not going to fall. Like, so what's really interesting is that the PPPD patients, even though like they score very high on like dizziness handicap inventories, and they're very miserable, they rarely fall, right? And so I think that where the vestibular rehab can be helpful is it's almost that cognitive part of it. Like, you're okay. Your balance is actually pretty good. And when you feel like you're going to fall, here are some things that you can think and you can do, right, to get yourself out of that situation. But again, I think it's a story that you tell the patient to say, let's just work on this, slice of your problem. Let's see how much mileage we get from this. So.
Okay. Thank you very much for this lecture.
Yeah, excellent questions, by the way. Thank you very much. Got a lot of hardcore people hanging on here.
Thank you very much, Dr. Chap. Thank you.
Yes. I know you're like 1 hour ahead of me too, so I know it's the middle of your morning.
All right.
Anyway, if there's any other, I don't know how long you're supposed to go. Are we supposed to go until 10:30 your time?
Yeah, 10:30. So
okay. Yeah. So any last wording? Someone?
I mean, we're almost there. Here? Almost there.
Yeah.
I think. Yeah. Yeah. Thank you again for the great lecture, and thanks everyone for joining us today.
Yes,
And
thank you. It was really nice meeting you all. Hopefully I'll come out to New York sometime.
in person, yeah, that would be great. Thank you.
Okay, have a good rest of the day.